to start the video?
Welcome. They're going to start in the back room.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. Yeah, we can both be heroes, like soldiers in their nice clothes. Like soldiers in their nice clothes, together. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this, like sailors in a tempest. Like sailors in a tempest, together. And it could be just you and me. We'll be family. Just wait and see. So I'll be brave if you're brave. I'll be brave, but only if you're brave.
Good evening, everyone. Welcome to Lung Cancer Living Room Dallas. Thank you all for coming, everyone in the room, those of you online who are joining us from wherever you are sitting tonight, hopefully having a glass of wine like everyone in the room here tonight is. We're so excited to be here in Dallas. This is our second time doing a regional living room out here in this part of the country, and we couldn't be happier to be here. So welcome. For those of you who don't know me, my name is Danielle Hicks. I work at the Adario Lung Cancer Foundation. I am Associate Executive Director overseeing patient programs and services. So everything that has to do with patient touch, education, voice is my area of responsibility. I, of course, do not do that alone. I have a team of amazing people, some of whom you may know, helping us to get everything done that we're getting done. So a little bit of housekeeping. If you guys have cell phones, if you wouldn't mind silencing them, that would be great. And then I want to remind people that we are online and in the room, that we are here for you. We do this for you, the patient, the caregiver, those people seeking information and education about this disease. So we really encourage Q&A throughout. So please don't be shy. Raise your hands. Nicole and Kristen, I don't know where your mic is, but we will, there's only one? Okay, so if you raise your hand, someone will come over to you with a mic. We ask that you use the mic so that people online can hear your questions, because your questions may be very relevant to somebody that's either watching live tonight or someone who will come back and watch this post live. So please ask questions throughout. We typically start, for those of you who may watch the living room that we do the third Tuesday of every month from California, with an around the room. So it's absolutely not mandatory. You do not have to tell me who you are or why you're here. But we like to hear from you. We like to hear who you are and why you're here. So I'm going to ask Nicole to kind of start it around the room if somebody would like to be brave enough to tell us who you are. If you're a patient, just a quick, Charles gets to go first. Thanks, Charles.
I'm Charles Forsham. I'm a 10-year cancer survivor, patient of Dr. Gerber's, and I'm on the board of the Adario Foundation.
I'm here to support my husband.
I'm Donna Fernandez, and I am also a patient of Dr. Gerber and Melissa, and I'm a 6.5-year survivor so far.
Hi, I'm Stacy Hsu, also a patient of Dr. Gerber. And I was diagnosed in August 2017.
Hi, I'm Gail Lemaire.
I'm a patient of Dr. Gerber's and Melissa's also. Funny how we flock together. I've had lung cancer since 1992, and I've had it about 5 or 6 times now, along with some other cancers too.
Hello, good evening. My name is Om. I come here for my father. My father is a patient of Dr. Gerber.
I'm a Kirkpatrick girl.
And I've been healthy and cancer-free since 2009.
My name is Melanie. I am a lung cancer survivor. I'm a patient of Dr. Kirkpatrick, and I was diagnosed almost 4 years ago in 2015.
I'm Robin Hawk, and I've been Melanie's caretaker, and I'm also a very fast learner. This cancer stuff is something I knew nothing about, and now I feel like I have a PhD.
Hi, my name is Ravi. I'm a patient of Dr. Dawal at UT Southwestern, and I was diagnosed 1.5 years ago, stage 4 patient.
My name is Roger Hansen. I'm a caregiver, and my wife is Cynthia Hansen, and she's getting care with Dr. Gerber, and we're at that battle stage, so wish us well.
My name is Ron, and I am Mary's Uber driver.
Good evening. My name is Doris Lewis. I'm the wife of Jay Lewis.
My name is Jay Lewis, and I will be taking my last treatment from Dr. Kirkpatrick in June.
My name is Ricardo Pinella. My wife is a lung cancer survivor. Dr. Gerber is his doctor.
Hi, my name is Ricardo. This is my father, and my mom is Dr. Gerber's patient, along with Melissa. And she was diagnosed a year ago, stage 4, ROS1, and thanks to their help and the medicine, she's doing a lot better this year than she was a year ago. So.
Hi, I'm J.M. Barnish. I'm a patient of Dr. Gerber's and Melissa, and I'll be 1 year cancer-free on May 2nd.
My name is Casey Hamill. I work with Foundation Medicine, and I'm here just to be supportive. Thank you for having me.
And my name is Janine Young, and I also work in research. I work for Genentech. So I have had quite a bit of experience working with Dr. Gerber in lung cancer trials, as well as I have been on the personal side in that my sister was a patient of Dr. Kirkpatrick's. So I was especially interested, as well as I have been to several of the Adario programs and lectures at various conferences and meetings across the country, and I always learn from patients, from advocates, as well as from the actual researchers. So thank you again for allowing me to come as well.
I'm a Kirkpatrick girl as well. My name is Sharon Kirkpatrick, so Dr. Kirkpatrick is my husband.
Excuse me. My name is Ben Garcia, and I was fortunate enough to work with Dr. Kirkpatrick for a couple of years in the lung cancer navigation program.
Anyone? Did I miss anyone? I did, right up in the front.
Nobody wanted to sit in front.
Here you go, sir.
My name is Jim Morrison, and I'm also a proud patient of Dr. Gerber and Melissa. I've been cancer-free for 3 years now.
So thank you all for sharing your story in the room. Michelle, does anybody online? I don't see Michelle. There you are. Nobody wants to make an introduction right now? Okay. Okay. So what I'm going to do next is I'm going to turn over introductions to this amazing panel for those of you who may not know who they are. Doctors Mason, Kirkpatrick, Gerber, and Nurse Melissa, who, from what I understand and what I hear around the room, is quite extraordinary. If you guys wouldn't mind introducing yourself, I was explaining to them earlier that I used to do the introductions for them, and it felt really impersonal to me because I was reading from a piece of paper who they are, what their background is, why lung cancer matters to them, and I think it's way more personal to hear it from them. So Dr. Mason, if you wouldn't mind starting.
My name is David Mason. I'm the Chief of Thoracic Surgery at Baylor University Medical Center. I've been here in Texas coming up on 5 years now. I grew up in the Northeast in Boston, and pretty much everything I do is related to thoracic surgery and thoracic oncology. I do lung transplant as well, but most of what I do is lung cancer. That's what I do the vast majority of the days. How did I get interested in lung cancer? I'm not exactly sure. I think what I enjoyed about it and what I found fulfilling was the complexity of lung cancer and the many different nuances, and the fact that most surgeons who interact with patients in their lives interact very transiently, and I didn't like that. I like to become part of patients' lives, and I found that as a thoracic surgeon in cancer that I became part of patients' lives, and I would see them on a long-term basis and grow with them and rejoice with them and cry with them or suffer with them when bad things happened as well. But I like the fact that there's a lot of thought in terms of treating lung cancer, and you'll hear a lot, I think, today about what's new in lung cancer and the many different ways that we have to treat lung cancer now. It's changing very quickly, and the challenges, the daily challenges that come with treating patients with lung cancer.
Thanks, Dr. Mason.
My name is Kirkpatrick. I'm a medical oncologist, and I'm at Presbyterian Cancer Center in Dallas, Texas Oncology. I kind of gravitated to lung cancer, I think, because of the patients. As you said, I think when I've been doing it now maybe 15 years, and it's just when we first started, lung cancer was still sort of one size fits all, and I felt like we really needed, to me it was exciting to try to help patients navigate and then get into this area. Now we're starting to individualize and targeted treatments, and now with immunotherapy, it's just been so exciting and to be a part of that, but also being a part of the lives of our patients. That's just my favorite part about it. And I have a connection with the Bonnie Adario Foundation because we started doing the run in Dallas probably about 9 years ago. I went to the first run. So I remember I was telling somebody, we had the run and we went across the street and had like 8 people after the event having a beer at the Stoneleigh Peak. And now it's gotten much bigger, and it always makes me proud. It's one of my favorite things to do every year is be a part of the run. So just happy to be here, and thank you for having me.
Thanks, Gil.
And my name is Melissa Mayer. I'm a certified oncology nurse as well as in hospice and palliative care. And how I got interested in cancer was I was actually in nursing school, and I got selected to do an internship at Parkland for 3 months. And I wanted to do like the ICU or the ER, something exciting, and we actually just drew floors out of a hat, and I got assigned to 7 East, and it was oncology, and I thought, oh no. And then after being there for 3 months, I was begging to at least work part-time there because I fell in love with my patients, and it was definitely a rewarding job, and that's when I found my calling. So that's pretty much my interest in. And I've been in ever since I graduated. The first thing I did was beg for a clinic position, and so Dr. Gerber and I have worked at Parkland, and now we're at UT Southwestern, so I think we're a pretty good team.
I'm David Gerber. I'm a medical oncologist who specializes in lung cancer care and research. I've been working for Melissa for about a dozen years at UT Southwestern. I divide my time between designing and conducting research studies and also running a lung cancer clinic. Together they add up into about 135%. What got me interested in lung cancer, I think, was mostly a combination of what you've heard so far. Loved taking care of the patients when I was doing my training and fellowship. I also really love the fact that so much of the care is team-based. It's not just the medical oncologist, but it is oncology and radiation and surgery and palliative care and pulmonary medicine. And I didn't see any other field that was changing in such rapid and exciting ways as Dr. Kirkpatrick mentioned. So put all that together, and that's what got me here.
That's great. So some of the things we're going to talk about tonight are going to point towards, cancer is not exciting for any reason to a patient. There's nothing exciting about being diagnosed with any kind of cancer, right? But what is exciting for the folks that work in it, and some of the things you're going to learn tonight, from screening and early detection and surgery, you know, right on through even treating metastatic disease in a way that we never treated it before, right? And we're going to talk a little bit about, you know, in the last, you know, small handful of years, the amount of drugs that have been approved that, you know, is a huge number compared to the amount of drugs that have been approved over the last couple of decades, several decades, right? So things are exciting in lung cancer right now because of that very thing. So I'm excited to share all of that with you and those of you online. We're going to start a little bit with talking about screening, which I know is irrelevant to most, if not all, people in the room and watching because you've already been diagnosed, right? But what we view it as and why we would like to educate this population on it is because we think it's an opportunity for you to have a conversation with someone who might qualify. There's, you know, roughly between 9 and 10 million people in this country alone that currently qualify for screening, and roughly 2% of people actually go and get screened. So there's sort of this low-hanging fruit that you guys are the perfect folks to go out and be sharing this information. So I would like Dr. Mason to talk a little bit about screening protocols and what that looks like, and then we'll jump into some amazing changes in thoracic surgery.
Sure. Well, I mean, I think most of you know that lung cancer, if it can be cured, the chance to cure it is in its early stages. That doesn't mean there aren't exceptions, but for the most part, curability comes in its early stages. So obviously the question is, how can we find cancers in their earliest stage? And there have been a lot of different ways and a lot of different attempts to find patients and to screen patients. And screening in terms of, you know, the logistics of it can be quite challenging, but to screen patients and try to find it in an early fashion. And there have been many attempts, but really the one proven method, and while there are many other investigational techniques right now, the one proven method that clearly finds cancers early and saves lives is through CT scans. So they call it LDCT, low dose CT scan, and basically patients who carry risk factors for lung cancer, and obviously we know that the greatest risk factor for lung cancer is smoking. Those patients who carry risk factors should be screened with a low-dose CT scan to see if there's something on the CT scan that suggests that they might have lung cancer. So there are programs throughout the country, and I'm sure in everyone's city for the most part, that offer CT scans for people who are at high risk. And without going to the specifics of numbers and ages and pack years or whatever, it's basically patients who are a bit older, because it takes, you know, patients who get older, have the opportunity to develop cancers, who are a bit older and who have smoked in the past or are active smokers should be screened with low-dose CT scan. It's just something that your primary care physician should note as part of their evaluation. It's kind of like you get a PSA or a colonoscopy at a certain age, you should get a low-dose CT scan. So, you know, that's what people should be having done. The one thing that I like about it is that it's something that clearly should be done and has the opportunity to find early cancers. The one thing I don't like about low-dose CT scan, or not necessarily, about the concept of screening in that population, is because many patients are not smokers. It sort of focuses more on smoking, and I don't like that sort of stigma that it becomes attached of a self-induced disease and smoking. That being said, if you are in that category, you should get screened. But that's not all there is to screening, and there are other, maybe you might be able to talk about other opportunities for screening that aren't necessarily as, proven, but clearly getting screened is important, and it should be something that your primary care physician should be doing.
Yeah, it's a challenge, and there's a lot going back to screening, whether it was mammography or colonoscopies and all of that, where there are lessons to be learned there. But lung cancer screening is interesting. I'm going to share a quick story, and then I'm going to ask for feedback on screening. I was recently at the doctor's for something trivial. It wasn't a big deal, but I was sitting. It was my GP, and I was sitting in the not the waiting room, but the whatever you call it, the room waiting for him to come in. And there was this ginormous poster on the wall talking about sort of screening protocols and vaccination protocols, literally from birth through life. And it categorized it by age, right? This is when you do this, this is when you do this, this is when you do this. And of course it got to I think it was like 49 to 65 or something range. And there was nothing in there about low-dose CT screening for lung cancer. And I thought, well, this must be an old poster, right? And I was like, no, it was like 2018. And I'm like, now I'm feverishly like trying to find who do I email at this hospital to let them know that this is not acceptable, because why are we missing that mark, right? And there's a ton of reasons and I don't want to make this all about screening, but again, it points back to an opportunity for you guys to share this information that screening is available for, to Dr. Mason's point, a small percentage of the parameters aren't as big as we'd like it to be, right? They don't include never smokers and that sort of thing, but it's a start. So any comments?
Let me just say, we had our meeting, we have a monthly meeting where we look at all our screening CTs at our program. And it's not just getting a CT. I mean, you get a CT scan, and then if there's suspicious findings, we review it, like in a tumor board setting where you have a surgeon, typically a radiation doctor, sometimes we have a pathologist in there. It's a multidisciplinary review, and so the CT, if there's a concerning finding, it's getting reviewed. If it's done properly, that's how most programs are set up. And so it's not just getting a scan; it's getting it reviewed, and then so when we get the word out to the internists that, hey, not only is your patient getting a scan, but if we find something suspicious, we're evaluating it and we're coming up with a plan. So I think, I just think it's more, we just gotta get the word out better. You're right, it's not, we haven't done enough to promote that in the community. You don't see advertisements about it for some reason. We need to be better about advertising this great service, because it's really important. It's really an important thing for patients.
Thanks.
I'll add a couple more thoughts. I think one of the reasons why we haven't seen as much CT screening uptake as could occur and as I'd like to see is that both the general public and physicians have been concerned about the complexity of the process, and some of that may be appropriate concern, and I think a lot of it isn't. So when a patient goes for a low-dose CT scan, the first thing you need to know is that it is indeed low dose. The amount of radiation is less than 1/5 a standard CT scan, so it's safer. It doesn't take a long time. The patient goes into the CT scan machine. He or she is asked to take a breath and hold it, and then exhale, and they're done. So it's done in a matter of seconds. And there's no IV contrast, so you don't need an IV placed, and you don't have to worry about allergic reactions or kidney toxicity. I think physicians were very concerned about low-dose CT because when you do very sensitive imaging studies, you see a lot of stuff. You see a lot of dots in a lot of people. As a matter of fact, in the trial that was done over time, 40% of the people in the study had dots that needed to be followed up. Didn't mean they needed to be removed or biopsy needed to be done. Of those, a very small percentage were cancer. Well, by 2019, what we have now is a system similar to the formal system that's existed for mammography for decades, where we have formal criteria to follow up all of those scans and rate them and decide which ones need to be evaluated in a special way. And when you use that system, less than 10% of the time do you need to do anything besides continue once-a-year screening. And the other thing to remember about screening is that it really is effective. The number of mammograms that you need to do to save a life from breast cancer is about 800. The number of sigmoidoscopies you need to do for colorectal cancer is about 700. The number of pap smears that you need to do to save a life from cervical cancer is over 1,300. And the number of CTs you need to do to save a life from lung cancer is 300. So by a factor of more than 2, it's the most effective cancer screening that exists.
That's a great point. We're gonna use that soundbite somewhere. I'm certain of it. I'd like to kind of jump into early stage disease and how surgery really has changed. So also for those of you who don't know, Bonnie of the Bonnie J. Dario Lung Cancer Foundation is my mom. So she was diagnosed in 2003, which was when lung cancer entered my life, and I've been doing nothing but lung cancer since then. But she wasn't offered actually any options at the time, and without going into it, ultimately she wound up having surgery after being treated with chemotherapy and radiation up front, and she's still here today. So that's a big, big deal. But things have changed a lot since then. So I'd like to talk a little bit about video-assisted thoracic surgery and Da Vinci and all of that kind of stuff. So I'm going to turn it over to you. First, but also who qualifies and how does someone qualify for surgery and what does that look like?
Let me just ask, who's had surgery for lung cancer out there? So a lot of people. How many people had like a big incision versus like big incision? How about a telescope? Little incisions? Little incisions, okay. Wonderful. You know, stepping back and looking at surgery, and I think you're going to also talk about surgery at some point for more advanced cancers as well, but surgery for, you know, sort of more early stage. Everyone knows they're staging a cancer. Almost all cancers are stage 1 through 4. 1 is the earliest, 4 is the most advanced. Without going into the exact specifics, 1 means basically you got a spot in the lung. 2 means you got a spot in the lung and maybe a little bit of spread within the lung or into lymph nodes or drainage basins of the lung. Stage 3 means those cancer cells have left the lung and are starting to get more into the center of the chest. Like breast cancers tend to spread to the armpit, to the axilla, so they sample the lymph nodes. And in the chest cancers, lung cancers, they tend to spread to the center of the chest. So lung cancers that have spread to the center of the chest but have not exited the chest are stage 3 lung cancers. And then finally, stage 4 lung cancers are cancers that have traveled elsewhere, more distantly, to the brain, to the liver, to the bone. In general, lung cancer is reserved for patients with stage 1 to 3 lung cancer, so cancers that are within the chest. Surgeons can only treat what they can locally, remove the tumor. It's nothing, you know, so fancy. Take the tumor out and everything in that region. So stage 1 cancer, stage 2 with the lymph nodes, and even stage 3 cancers, which you tend to treat with multiple different treatments, usually before the removal of the lung, or cancers that we operate on. So that hasn't changed a lot, I would say, in a long time in terms of what operations we do for patients and who are candidates for surgery. In terms of how we do it, that has changed significantly. You know, in the old days, which wasn't that long ago in my training, and which wasn't that long ago, I finished training in 2003, you know, almost every operation was done with what's called a thoracotomy, or you make a good sized incision, you spread the ribs, you take out that piece of lung, you close the ribs, and the recovery is challenging and it hurts and it takes a while. You know, we still remove typically a lobe of the lung. You probably all know that there are lobes of the lung. The right lung has 3 divisions or 3 lobes. The left lung has 2 lobes. That's just the way it is. I don't know why. And we typically, you know, most cancers live in a lobe of the lung, sometimes right smack in the center and require removal of the whole lung, but usually in a lobe, and we typically remove the lobe of the lung, remove the cancer, the drainage basins of the lung, and that tells us if there's movement, whether we need to give other treatments after surgery, that type of thing. Nowadays, most lobectomies, or removal of the lobe of the lung, can be done with little incisions, no rib spreading. small incisions that, typically people are able to go home with, home from in a couple of days. There's VATS, video-assisted thoracic surgery, using a telescope and small incisions and instruments attached to the surgeon's hands. And there's robotic surgery, same small incisions, instruments attached to the end of a robot. I do both, which is better. I don't know. I don't think it matters that much. I don't think most people really believe it matters that much. But the point is that it's with little incisions without the rib spreading, and patients seem to do better without compromising the cancer component of the operation. Obviously, you want to remove the cancer, remove the drainage basins, and do the same operation that you would do with a big incision through a small incision. So most patients can have that done now, and I think that's made a difference in terms of patients that we can operate on, patients who are able to, were a little bit more fragile in the past, I think get through it easier. I don't know that it's changed necessarily the survival of patients, but certainly I think it's made the recovery faster, and certainly an operation that we want to do and everyone should have the opportunity to have in the appropriate setting.
So I just want to, I don't know anything about using VATS. I mean, I know about the surgery, but I just want to share a little story that the company that makes the robot happens to be in Northern California, and I went down there and I actually got to play with the robot. So it might not be any better or worse or whatever than VATS, but it's really fun to play with. You take these little rubber bands and you put them around these things. It was kind of interesting. So, you talked a little bit about stage 1 and 2. Talk about somebody like Bonnie. So Bonnie's tumor, she was diagnosed stage 3B. It was in her upper left lobe. I always kind of compared to tumors and what some of them do when they're looking for blood supplies to wrap themselves around those blood supplies, right? So it attached itself to her aorta and her subclavian artery. So that was why she was a non-surgical patient, because in 2003, nobody was really touching that, right? They told her to go home. Then she met with David Jablons, who some of you may or may not know, who ultimately wound up doing her surgery. He's a thoracic surgeon at UCSF, and was like, okay, and along with her medical oncologist said, okay, well, we'll give it a try, like no guarantees. And she's like, well, I'm not gonna die because I did nothing, right? So let's do this. So she had chemotherapy and radiation up front. She did have a thoracotomy, so she's got that huge scar, and the recovery from surgery was rough. But also while she was open, and we can talk a little bit about this a little bit later, or maybe we'll talk about it now. When she was open, they gave her a high dose of radiation into her chest cavity, and then she had cardiac surgeons in there repairing the vessels that went to her heart. So it's 2004. That's a really big deal, right? It's more commonly done now. So talk a little bit about that patient, because quite often at the foundation we get calls from patients who are like, well, they say I'm not surgical and I want to know why, and they aren't really told why, right? Whether it's even. So talk a little bit about when you're still maybe potentially doing it for a curative effect in some of those locally advanced cases, and when you might be doing it to manage disease in maybe some of the metastatic patients.
Right. I mean, so in terms of local disease, I don't know if, does everyone understand what local versus distant disease? Would anyone like me to explain that a little bit more, local versus distant disease? No? Well, I'll say something.
I would like to.
Local disease means the disease lives in the spot of the cancer, and then distant disease means that it's traveled elsewhere. And in general, not exclusively, in general, surgery is for, best, in terms of the efficacy of the operation is best for patients with local disease. And what I often tell patients who, when I say I don't think we do an operation, is that you can't remove part of a cancer and leave some behind and feel that you've done anything of any value, because even just a few cells, they'll grow so quickly. It's like planting a grass seeds, and all of a sudden you get a whole lawn that looks in front of you. So if you're not going to remove something in its entirety and have what's called a complete resection, for the most part there's no value to that operation. All it gives is pain and complications and recovery, and then usually, a delay in therapies that might be more effective, whether that be chemotherapy or radiation therapy or whatever other therapy there remains. But there are people, certainly, that fall in the category that their disease involves lots of very important structures that, with, a sophisticated team of surgeons can take out and put back together again in a reasonable fashion. And you know, those, like your mom, you know, those patients, I believe, do benefit. And certainly, you know, resectability or removability is often in the eyes of the beholder. So I think that a second opinion is, you know, is warranted for patients who are uncertain about their diagnosis. And I don't think there's anything ever wrong with it. And certainly when patients tell me, I'd like a second opinion, I'm never offended. I feel like, you know, it's your life, it's a very important decision, and go get another opinion. And I think that if you try to steer patients away from that, that's the wrong thing to do. So I think that, you know, again, removal of something in that one area that's very big and very advanced, they don't come around that often because usually they've moved, usually they've traveled, but every now and then it is feasible, and it makes a difference who does the surgery, honestly.
That's what I was just going to ask. So how important is it, because I know quite often, I mean, the number of certified thoracic surgeons in this country, it's growing, right, but it's not that big when you look at sheer numbers of patients diagnosed, right? So how important is it maybe for someone to get a second opinion from someone who that's all they do is thoracic surgery versus a general surgeon or a cardiothoracic surgeon who more often than not is focusing on the heart?
Right. Well, this would be very
this would be
a very biased.
Yes.
Well, removing the bias, what I would say is that you know, I don't know how you choose a doc in general, you know, whether it be, you know, looking at the ratings online or Yelp or this or that or a personal referral. I don't know how people find doctors, honestly, or how they find their way to me necessarily. Usually it's through somebody that you trust. So I think that's one thing I would recommend. Find a referrals from that you trust. And not everyone has some direct link to a thoracic surgeon. So I don't honestly know how the majority of the world finds their docs to take care of them.
I think they go to the hospital
They go
down
to
the
the hospital.
road. Yeah.
So, you know, obviously you want to ask the questions, you know, how often do you do the surgery? And, you know, how many do you do a year? And can you give me an idea of what your outcomes are without necessarily going into specifics? If you look at the world of thoracic surgery, in terms of who operates on the lung, there's several people who operate on the lung. And I haven't seen the statistics recently, but they're surprising to me. And the last time I looked at them, which wasn't that long ago, and I doubt they've changed that much. There are what we call general surgeons, or people who operate on anything from your appendix to your lung, who do lung cancer surgery. There are people who are cardiothoracic surgeons who operate on things in the chest, the heart and the lung. And then there are thoracic surgeons, and I'm one of those people, who operates only on the lung and only on lung cancer. And you know, the world is very complicated, as you all know, and you know, very sophisticated. And I believe that people who focus on one thing tend to do a better job at that one thing. Because you know, one thing I mentioned to you at the beginning was I like taking care of lung cancer because there's complexity to it. And I focus on that, and I think about that, and I think people who think about lung cancer not only in the technical conduct of an operation, but who deserves that operation, what exactly is that operation I perform, when should I perform that, before chemotherapy, before radiation therapy, after therapy, you know, all those things. I think those are all important things to consider. People who are going to work with the team and not make the decision on their own. Like they walk into that office, I'm doing an operation, well, you know, what does Dr. Kirkpatrick think, or what does Dr. Gerber think, or what does the radiation oncologist think of all this? How are we all going to think about this together? And I think thoracic surgeons tend to work more in a team fashion to make decisions about when to operate and who those patients to operate on. So I think that's important, sort out who does, you know, just one thing. I think focus, you want your heart operation done by a guy who does heart surgery. If I want a heart operation or need a heart, I want a guy who does heart surgery all day.
Yeah.
Not on Thursday afternoons.
Yeah.
You know, not really. Yeah.
So important questions to ask. So I'm glad you brought up sort of this team approach, and Dr. Kirkpatrick brought it up earlier, a multidisciplinary team. If as a group, maybe you could explain what a multidisciplinary team is and how you make decisions together about even, we're still kind of in this surgical sort of stage. How does that, what does that look like? And one question I have, which I get from patients all the time, is how do you determine who might need some sort of systemic treatment prior to or after surgery? So we'll save that for you, but if we can all chime in on the multidisciplinary team.
Well, my thought about multidisciplinary care in oncology, and it's not just seen in lung cancer, but most cancer types involve group tumor boards and input from multiple different physicians, is it just reflects how complex the disease is. You know, no offense to my colleagues who are internists, but if someone has elevated blood pressure, there's usually a single intervention that's relatively straightforward that can address that. And because of all of the different variables that come into play with a disease like lung cancer, where the tumor type and location and stage and molecular profile can all be different among patients, and then the patients themselves can be different in terms of their health, their ability to get surgery, their other comorbidities, and their preferences. You add all that together, and oftentimes there's not just one obvious right answer. And I think there's really not only added benefit, but some comfort in knowing that multiple people have thought about the case to make a group decision.
I think the case that you brought up for Barney and your mom, there are some, I think we were talking about there are stage 3 patients earlier, and you say it's not one size fits all, because now we do have to get together and make these decisions with the surgeons and say, yes, there's a lymph node, but maybe it's one lymph node. Can you take out one lobe and not do a complete lumpectomy, which is the entire lung? You take all these things into consideration. There's probably going to be a time we take that patient who would just have gotten chemoradiation, and then we're going to do upfront neoadjuvant treatment, which means giving treatment before operation. We do that in breast cancer, we do that in colorectal cancer, and so that's evolving. So the stage 3 area is an area that hasn't had a whole lot of change. It was everyone typically would get chemoradiation, and that was it. Now we have immunotherapy that we're giving after chemoradiation, and then there's select patients that might have one positive node that feasibly maybe we can give them treatment first and then think about operating. But these are cases that we'd have to discuss as a group. And to come back on this point about second opinion, I agree. I think when you think about if someone's diagnosed with cancer, it's the most important thing that they're facing probably ever in their life, or one of the most important challenges and decisions they have to make. And so I think getting a second opinion, no matter what you're talking about, who you're seeing, is normal. And I always tell people that. I think when I first started practicing, I guess I kind of almost, it wasn't like I was offended, but I was like, wow, the patient doesn't like me. But, then I started to think about it, after doing it only didn't take that long, was to think, what if it was me? What would I want to do? I mean, I would want to make sure, and my family would want to make sure, that we looked into every possible scenario. Now, what I do tell people is sometimes you have to think about the timing. If something is going to take a long time to do, and you probably don't want to get 3 or 4 opinions, because next thing you know, you're traveling all over the place. It's been a month, and we probably should have done something. But I don't think anyone should ever feel, I always get that statement, doctor, I didn't want to offend you. And I say, look, I understand, this is what I would do. I totally support this. But just let's try to we just want to help you expedite it. Let's try to get it done in a reasonable time. The second opinion is normal, and I think if you ever feel like you want to get a second opinion, that is more than reasonable, probably should. But I think bottom line is, all these cases now, it's evolving. And I think meeting with, as a team, like David said, think about cancer of the lung, it's not just surgeon takes care of it, it's not just medical oncology. It's radiation, it's pathologist, it's our interventional radiologist. We all come together on some of these cases because we have to come together with a plan. So as long as you feel like you're getting a good plan, and there's communication, then that's what you're looking for.
And we're gonna jump in a little bit into sort of what good looks like in that sort of space. But before we go there, you said something that kind of resonated with me, and again, talking with patients, one thing that happens less frequently than I'd like it to is what sort of the buzz language around now is shared decision making, and physicians and nurses having those conversations with patients about goals of care. How important is that in what you all do for you to be doing that with your patients? Dr. Gerber, I'm going to start with you just because you're sitting to my left.
Well, I think for me, understanding patients' goals helps me align my goals with theirs. For instance, it's not that infrequently that someone asks me, how long do I have to live? And I usually answer that question with another question, and that is, why do you ask? And it's amazing how often there's a specific reason or a specific goal, or there may be the misunderstanding or misconception that once I start treatment, there's going to be no flexibility and I won't have a chance to go visit my family in Vietnam or see my son in Missouri. And the fact is that we can tailor just about any treatment, and that's not just standard treatment, but even clinical trials, to someone's availability and their preferences and their goals.
Anybody else, or just agree?
Well, I mean, I think shared decision making that's the best part of practicing medicine. I mean, I think for me, I mean, there's every different style of doctor, right? I think some people want a paternalistic doctor. They want you to tell them what to do, and I tell them that's not going to be me. You're not going to tell me what to do. I'm not gonna tell you what to do. Let me explain to you what I think is a good plan. Let me tell you the pros and cons. I want to know what your thoughts about it. And this is kind of what we're getting into, and we're going to do it together. And I enjoy that part of it. So I think shared decision is something, it's just a way of practice, and it should be, I think it's the way to do it. I mean, another funny thing you ask, I get the question is, what would you do if this was your wife? And I said, well, first thing you got to ask me is, do I love my wife? Yes, I love you, Brandon. And this is what I would do. But that was, no, but people, they want to know honesty. They want you to, if you tell them, I want to outline it to them. This is the side effects that we could be getting into. This is, this is realistically what we're trying to achieve. Make sure you're open with it up front. Mr. Lewis over there told me, and then the first day he met me, he says, Doc, I'm going to beat this. And I said, I think you are. I love your attitude. I love that positive attitude. And he tells me that every time, reminds me every time I see him. But no, you have to figure out each patient individually, and they figure out you. And that relationship part, and that negotiating, not good negotiating, but that interplay and sharing with them in the journey and decisions is, I think, the most important part of what we do.
So I think that's a good sort of segue into, that being sort of how personal that conversation is and how personal those goals of care are to the patient, into talking a little bit about literally personalizing the treatment plan. So I want to talk somewhat about upfront diagnostics and what that should look like and for whom it may or may not be appropriate. You guys just keep looking at me. Nobody's just jumping in.
What do you mean by upfront diagnostics? Like biopsies and things like that?
Yes.
Or?
Mm-hmm.
So I'd be happy to take a stab at this. And then Melissa, you're welcome to add your part, because actually the reality is often very different than the goal, and that's an important distinction. The first thing to understand is that, say 12 years ago, we understood lung cancer just according to the pathologic subtype. There was non-small cell lung cancer and small cell lung cancer. And within non-small cell lung cancer, we had some various subtypes. For the most part, most of those distinctions never impacted the choices we made for treatment. That was just something the pathologist noted, and we kept that in mind. And now in 2019, we recognize that lung cancer is probably 24, 25 different diseases when it comes to the molecular makeup of a cancer. And increasingly in oncology, not just lung cancer, but other types of cancers, we may focus even less on where did the cancer come from in terms of which part of the body, and rather, what is the biology of the cancer? And there may be some lung cancers that are treated quite similarly to breast cancers because they share the same molecular origins and the same molecular targets. Molecular targets have been important in breast cancer for a long time. We've looked at estrogen receptor and some molecule called HER2 for several years and even decades, and used that information to guide the treatment of that disease. And in that disease, historically it's been very easy to get that information up front. And that's because most breast cancer cases are treated early on, where it's removed with surgery and there's a lot of tissue. So that's the first distinction from lung cancer. Whereas we've already discussed, most lung cancer cases are diagnosed at relatively advanced stages, where needle biopsies are done and provide much less tissue. And it just depends on what type of needle biopsy, whether we may have enough to do the molecular testing, or we may not have enough to do the molecular testing. The other difference is that in breast cancer, the molecular testing is important for every single stage of the cancer. So when the cancer is diagnosed, automatically all of those tests can be run immediately once the biopsy is done, before they even see any of the treating doctors. In lung cancer, unless it's part of a clinical trial, these molecular tests are only relevant for stage 4 disease and that decision making. And so it can be challenging for the person ordering or performing the biopsy or the pathologist to know, is this a case where we need to have that information? And you can imagine a case that I might see where a biopsy was done at one hospital, saw an oncologist at a second hospital, and came to me for a second opinion, and now it's 4 weeks after diagnosis and those tests haven't been ordered. That's a big question, right? So how do we make sure this molecular testing is done? Because while not all patients are going to have a molecular target identified, each time we find a new molecular target, the number of patients for whom this could be relevant grows. And we have to remember that the therapy that we can use based on these diagnostics can be incredibly effective. So in a best case scenario, when I have the highest likelihood of immune therapy working in lung cancer, the chance of it shrinking is about 50%. But if I find a personalized medicine approach where I find a molecular target and I give what we call targeted therapy based on these diagnostics, that response can be 90%. So we can't forget about how important this is. The field has recently changed in a major way because for the first time, and this is less than 5 years old, we've been able to do these tests with blood tests. And this is an incredible advance. And I first became aware of this technology when my sister-in-law was pregnant about 4 years ago. And she said, we got the blood test back, and we're not at high risk for something like Down syndrome. And I said to her, I said, blood test? I didn't know you could do blood tests for that because I went through medical school, it wasn't a blood test, right? The obstetrician had to do an invasive procedure, an amniocentesis. Well, I learned that when a woman is pregnant, about 12% of the DNA in her blood is from the fetus. And so they could figure out through a blood test in the pregnant woman which parts of the DNA were from the fetus and test that. Well, when you have stage 4 lung cancer, even a highly advanced case, only about 1% of the DNA is from the cancer. So the fact that we can now do a blood test and identify subsets of those DNA molecules that are from the cancer that might show us important molecular information to treat the cancer is remarkable. When I do a blood test to look for a molecular target because maybe I don't have access to the tissue or we don't have enough of it, if the test comes back without a result, I may say to myself, well, maybe we need to do a biopsy because it might not have picked it up. But if it comes back with a positive result, and it found that result in 1 in 10,000 of the cells that were circulating, or the DNA that was circulating in the blood, that's a correct answer. And when I give a test on that result, I see results similar to what I would see based on the tissue. But I will tell you, it can be really challenging getting blood tests paid for. It still takes weeks to get those results. And the same is true for tissue. And I know, Melissa, you're nodding your head about that.
Yeah.
Anything you want to
I
add?
would say the blood test, we're usually about 10 to 14 days. But if you're running like the whole large panel, it can be up to 3 to 4 weeks. And that's a long time when you're newly diagnosed with lung cancer to wait around on that. So it's been a challenge.
So I think just a couple of things I want to note, and then I want to pause and see if anybody has any questions, either online or in the room. But there's still a lot of confusion, even in amongst clinicians, about tissue versus blood. And just to be clear, the blood stuff, for the most part, is still in sort of a research phase, right? Except for maybe some one-offs, whether it's T790 or something like that, right? But for these larger tests, and we haven't even gone into like any comprehensive testing, you mentioned HER2 and some of those things. And anyway, I don't want to get off track. That tissue is still sort of the gold standard. So just so I make sure that we heard you correctly, if you see it in the blood, you can be pretty sure it's there. If you don't see it in the blood, then you need to have a conversation with your physician about maybe going back and accessing tissue to ensure that it is in fact not there.
Yeah, and maybe I'll add a corollary to that, is that there are cases where the biopsy tissue is negative for a result, and I may send a blood test and it's positive in the blood. And you may ask, how is that possible? The biopsy is just filled with cancer cells. How could I not find it there, but find it when I'm trying to dig out little bits of DNA from all of these blood cells? And I think that has to do with what we call heterogeneity of a cancer. If I have a tumor that looks like this, and I do a biopsy, I'm only getting the part of the tumor where that needle went in. So what if that part, for whatever reason, didn't have that particular molecular abnormality I was looking for, but the part over here did? Mm-hmm. And some people feel that if those cases where it's negative in the tissue and positive in the blood, it's because the blood, even though it's relatively a smaller amount of cells, it might be a more diverse representation of the cancer.
And I think this is why a lot of the work that's being done right now in the blood space, be it for identifying, potential molecular targets or progression or even cancer itself, is so exciting. Going back to kind of how we opened this meeting about cancer's not exciting, but there are exciting things happening right now that once we figure it out wholly will have a really big impact on what all of this looks like. Gil, did you want to say something? Sorry.
No, I just think there's a lot of things to think about. I mean, if someone progresses on the current treatment and you can see an area, I mean, you'd like to be able to biopsy it, but the fact is sometimes it's hard to biopsy, or maybe you're not going to get at enough tissue. There are some. I think this is in flux about how to do the liquid biopsies and do a regular biopsy, if you can. I mean, there's one instance where, for instance, sometimes a cancer can actually mutate and maybe was what we call an adenocarcinoma that was maybe on someone's taking a pill because they had a mutation, and then if they progress, you're trying to find if they have a new mutation because there's another drug that targets that. But actually, sometimes that cancer cell can turn into a small cell or a different type of histology, and if you do a blood test, you can't tell that. So there are pros and cons, right, to getting tissue versus getting the liquid biopsy. Sometimes it's, I don't think I can safely get a biopsy. Patient doesn't want to go through biopsy, understandably. Liquid biopsy has a role. We're still trying to figure out, do we do both? Can we do one? Use, which one? The thing is, we're getting more information about how to treat the patients individually still, and that's the part that we figure that out. But again, it's individual. We have to take each case and figure out how to use these technologies.
And getting it paid for is,
that's a big problem.
It is, and I know, our foundation and others out there, although we don't pay for testing directly, we do work with several testing companies where we can actually help the patients access these kind of diagnostics. So that's a good point. Does anybody have a question? Oh, it's 6:50.
I apologize, everyone. I have yet another work obligation after this, but this is my first living room event, and it's been a real honor to have been in all of your presence, and I helped a little bit and didn't confuse too much. So thank you.
You helped a lot of it. One of the things I also want to just make note of, and we won't make a big deal out of it, but it's also Dr. Gerber's birthday. So a big round of applause and happy birthday to Dr. Gerber before he has to leave. We will go ahead and blow out your candles for you once the meeting's over. But thank you so much. And somebody will get you off mic.
Unmiked, correct.
Yeah, great. Thank you. So questions? Anybody? Michelle? Nicole? Anybody?
Best radiation for spine meds.
Sorry? Did you guys hear it?
Best radiation for spine meds.
Anybody?
Well,
we don't have any radoncs up here, but.
Well, I think, so radiation is a type of treatment that we use. Sometimes it's upfront if someone has a cancer that we want to give chemotherapy and radiation as their initial treatment. But sometimes you can use radiation to treat bone metastasis. I think that's what the question is. I mean, there are different modalities of radiation. External beam radiation basically refers to the concept of delivering the radiation beams to an area to treat it. And if you're treating the spine, you're typically trying to alleviate pain, because metastasis to the spine can be very painful. And so by radiating the spine, you're trying to alleviate pain. So normally it's going to be some form of external beam radiation. There's all different types of radiation now. There's proton therapy that's out there. But I think if you're talking about radiating the spine in general, external beam radiation, now the radiation oncologist can tell you how many doses they need to give. Sometimes they can give a few doses, of the same amount of radiation over a few doses, or they can spread that out over more doses, and they will tell you sometimes it's to do with how long it can last, the effect, or how quickly you need the results. So that's more a discussion with the radiation oncologist about how much radiation they can give, how many fractions, but external beam radiation is typically what they would use.
Is that it? Sorry, is there another one? Yeah.
I was wondering about the genetic test or the genomic testing. Can you go ahead and start chemo on somebody while you're waiting on the results so that they're not just sitting around letting the cancer grow while you're waiting on those results?
That's a great question, and that happens a lot, actually. If someone is diagnosed, and as you were pointing out, sometimes it can take 2 to 3, even 4 longer weeks to get a mutation analysis back. And so if you go on the premise of the chances of this mutation may be 20% roughly, and you might wait 4 weeks to find out that they don't have a mutation and you've delayed treatment. And so there's been times when I've started patients on chemotherapy, and then when the mutation analysis comes back, either change then, or if the patient's tolerating the treatment, chemotherapy still has a role. Even in patients with, for instance, like an EGFR mutation, there are chemotherapy drugs that still are effective. So sometimes I will go ahead and finish a cycle, or maybe plan to get 2 and then re-image and then use that genetic test when it's time, or automatically change if they're having toxicity. But it happens. Start treatment, get the results, and that would maybe change your next treatment decision.
Yeah.
My question has to do with my wife developed lung cancer, non-small cell lung cancer, and she stopped smoking very early. She probably smoked for about 4 or 5 years, and Dr. Gerber said that it wasn't caused by smoking. So what's causing the growth of lung cancer in people who don't smoke? And she grew up in Texas City, so there's a lot of refineries putting a lot of stuff in the air. So is there anything out there on what's causing it? Because it wasn't really genetics in the family.
Well, so I get asked this question a lot, and not just about lung cancer, or it's why did I get this cancer? There are people that may have smoked 2 packs a day for 60 years and don't get lung cancer. There are patients that never smoke cigarettes and get cancer. It's something, when I tell people, it's something about your genetics and your environmental exposure, some injury, whether it's a lung, there's some injury, a carcinogen that caused a mutation in a cell. And what cancer cells basically are they're cells that don't die. So something mutated, something caused a mutation in a cell, caused it to grow. Most cells are programmed to die. If it's not, it doesn't die and it grows and replicates, that's basically what cancer is. So it's not so much that people are doing anything that makes the cancer grow. We get questions about diet and sugar and things like that. But I think it's basically once a cell is mutated and it grows, that's the problem. So what the question is, what caused it to mutate? Some injury, some exposure, we don't know. I mean, I think in most cancers, I can't tell people why it happened. You know, we can tell them what you can try to do to try to maintain your immune system. We do think there's probably something about the immune system trying to keep it in check. So by eating healthy diet, getting exercise, mind over matter, you know, Pilates, yoga, whatever, certain things to get your body as strong and your immune system as strong as it can to help fight it. But in terms of what's maintaining it, I think once cells mutate and they start dividing and not dying, that's the problem. So we got to find the mutation that caused them to grow. We got to find, that's where some of these targeted therapies come in. Chemotherapy is what basically fake building blocks in a way. Cells are trying to grow and divide, and you introduce these fake building blocks so they can't sustain and they cannot continue to grow. But the problem is more about something initiation which led to this. So it's really a hard question. I get asked it a lot, why did this happen? Or, and unfortunately, a lot of times we don't know the answer.
Anybody else before I move?
Yeah, please.
In the next 10, 15 years, do you see immunotherapy overtaking chemotherapy?
Well, I mean, we already have situations now where we're not even giving chemotherapy to patients. In some situations, they have a stage 4 lung cancer, and we can give immunotherapy alone. And so I've got patients that have never seen chemotherapy. And so I do think, and I'm not saying that chemotherapy is going to go away, because I think there is a role for it, but I do think immunotherapy, other kinds of immune-related treatments, and then new other developments that we'll see. Immunotherapy has really revolutionized things in the last 5 years. You know, it's really changed the landscape and how we treat patients. I think there's going to be more discoveries, combination immunotherapy drugs, and maybe we will see a time where chemotherapy is really something we don't use that much, but I don't think it's going to completely go away. It still has a role, but immunotherapy has really, really changed how we treat lung cancer. And you're a great example of that.
Thank you. What can a person do to boost their immune system?
Well, I mean, you know, that's kind of what I was getting at earlier, is that, you know, there's not a lung cancer diet, I would say. But there's a healthy diet. There's, you know, eating right, fresh fruits and vegetables, you know, avoiding a lot of, you know, sweets, and you know, eating lean meats. You know, eat your fish and chicken, and don't fry your foods, and try to eat right. Try to get your exercise. I mean, but there's a lot to be said about the emotional part of it, and the psychological part, and the spiritual part of, you know, your mindset and your support system. That has a huge role. We don't know how to channel that. We don't know how to measure that. But I think it's a combination of all those things that make you healthy as you can be to help your immune system. I mean, there's a lot of things that are going to be targeted, you know, immune boosting medicines, and you just got to be a little bit careful about a lot of things that you might buy at a health food store that's really not regulated. I just think you have to be careful about taking a lot of extra supplements. We don't know how things interact with some of the medicines we're giving. There are things out there that are very helpful, but these are things you need to tell your doctor that you're taking, so we can kind of look into things to make sure there's no interactions. But I just say healthy diet, exercise, you know, and just finding whatever it takes to help you psychologically, spiritually, to to continue to come do your part where we give you the treatments and we work together.
So we touched a little bit on combination therapies, which I think is sort of a hot button right now. People are talking a lot about it, and chemotherapy plays a big role in that. And from this conversation, I kind of want to transition into the supportive care space because people are really afraid of chemotherapy. Whether it's combination therapies with targeted therapies or combination with immunotherapies, a lot of the data right now that's coming out pretty rapidly is showing an add value to chemotherapy in particular being added as it's sort of a cocktail, right? And we're kind of going more and more towards this personalized approach, how do I want to say this, in sort of varying stages, right, of of managing, I guess, the disease, and how long can you manage it by personalizing using variations of these combinations. Does that play a role in what you do?
Well, yeah, you know, think about, but before we had these immunotherapy drugs,
I'm
which
gonna
are
sit down too.
Yeah, have a seat. So immunotherapy, the drugs that we have nowadays that we're using are intravenous drugs, so they're still infusions, but in general they don't have that same toxicity profile that chemotherapy does. Now, not all chemotherapy drugs are the same. You know, we have plenty now that don't cause hair loss, and not all of them cause nausea, but they do eventually wear you down. I mean, they affect your blood counts, pretty much most of them. Eventually, you get to a point where you just can't stay on chemo forever. The interesting thing about immunotherapy is, you know, we don't know how long to treat patients with. In immunotherapy, I know most of you know what it is, but it's basically this idea of giving a treatment that programs in a way your immune cells to recognize the tumor cells and to attack the tumor cells. So sort of priming your immune system or training the immune system to attack the cancer. And so one of the things is, though, like, how long do we have to keep training the T cells, you know, the immune cells? Because we've seen it now where we give immunotherapy for a certain amount of time and then stop it, and then we keep scanning the patient and there's no change. And so that's the cool thing about it, is that at some point you might even get to, I've seen this quite a bit now, where you give chemotherapy maybe with immunotherapy, then you drop the chemotherapy, continue immunotherapy, then at some point you drop the immunotherapy and you're literally watching patients off treatment and going on trips and you know, living their lives and coming in and getting CAT scans. And the CAT scans aren't necessarily completely normal, but there's nothing changing. So we think that maybe at some point when you train the immune system, the immune system is still going to manage things and keep it in check so kind of treating it to a chronic disease is what you're ultimately trying to do. Is if we can do that, treat it like a chronic illness, people living longer and having, you know, healthy, not a lot of side effects, especially if you're not treating them, you know. That's the thing, is when can we stop immunotherapy? Right now, typically I'd say if you treat someone with stage 4 lung cancer with immunotherapy, once you get to 2 years, in general, we're stopping. And that was unheard of to even talk about, you know, 5 years ago, to say, all right, we're going to treat you, and then, you know, at some point we're going to stop and we're going to watch and be off therapy for a long period of time.
So when you stop the treatment and you watch if the disease starts progressing, can the patient go back on?
That's still, you know, I've seen that. I mean, immunotherapy right now, how to do it long term is, it's funny, all these trials, they never thought about how to manage people. Now I've got these people in these trials and they have to be scanned every 8 weeks, and they're like 4 years out and like, doc, do I keep getting scanned every 8 weeks? It's, you know, and I'm like, okay, well, let's back off. They didn't think you were going to live this long. I mean, people are doing so much better. But I think I've had patients that stopped immunotherapy and then a year later there was progression, and I've started it again and I've seen response. This is all sort of evolving. How do we manage it? But you can. I think, you know, combining immunotherapy is something that everybody's looking at. Sometimes that adds toxicity. So we've been a little bit, you know, spoiled with these drugs. Keytruda, Opdivo, these are the ones we've been using the most. Haven't had, I mean, there's some side effects that can be significant, but in general, they're really well tolerated. You start adding more drugs to get better response, sometimes you're seeing some toxicity. So we got to figure out, you know, how to combine them. We got to figure out how long to give them. Maybe figure out how the least amount we can give them. You know, that's something that is gonna need to is happening right as we speak.
I think it's one of the, there's some patients at the living room back at, in California, and they tell their story every month, and some of you, if you watch, may have seen, and there's a couple of them who are like, oh, I've been on my targeted therapy for 8 years, and they're like, and just, do I stay on, do I go off, like what do I do, is the Tarceva just suppressing my cancer, or has it cured it?
I think that's different than immunotherapy.
Yeah. But right. But what I'm saying is that there's this sort of like idea about how long to stay on, even in the targeted therapy space, where the questions are starting to arise about after somebody's been on Tarceva for 10 years and they're NED, are they effectively cured or not?
It's a good question. I mean, we're seeing that in this disease called chronic myeloid leukemia, CML. That was a leukemia that back in the day, all you could do was maybe a drug called interferon, which was very toxic. Maybe you get a bone marrow transplant if you could, but in general, you weren't going to survive very long with this disease. They came out with this drug called Gleevec, which was one of the first targeted therapy drugs. And we have people that have been on the drug 10 years, and now we're stopping the drug, and these people are still in remission. So that may play out with drugs like Tarceva, Alatinib, Gilitrif, these kind of drugs. Yet to be seen. There are maybe those patients that are on it for a long period of time, and maybe we can stop it. But it's kind of a hard study to do, and it's kind of a hard.
Well, it's a hard one to talk patients into.
Right, and if they're not having much, if they're not having a lot of toxicity, the cost can be a problem though. At some point, cost can be an issue. So we got to take that into consideration. But there may be certain times when maybe we'll stop targeted therapies. But right now, I would say if you're on an oral drug like for a targeted mutational kind of treatment, you stay on it. This idea of stopping, I think, is more in the immunotherapy world.
Interesting. So I want to jump. Are there any questions before I jump yet again? Yes, Nicole. Sorry, she's grabbing the mic. Right up here. Keep coming. Keep coming. If you raise your hand, sir, she'll. Yeah. No, there she goes.
Local consolidation therapy for stage 4 patients who are on different TKIs. I mean, what do you suggest?
Okay, so I need to.
If someone is who's on TKI drug, considering local consolidation therapy like radiation.
I know Dr. Gerber has a trial that he's looking at that, and that's, if someone has one spot, for instance, that may be progressing, and we see this sometimes in targeted therapy. Someone's taking an oral agent and the disease is under control, but there's one area that's progressing. There's actually evidence that you could maybe do stereotactic, which is kind of a short course of directed radiation, and treat that area and stay on the drug. Because as you mentioned, the heterogeneity, maybe the majority of the cancer cells are still under control with the pill. There may be a clone that escaped, and if you treat that one area and then stay on the drug, you can continue that drug longer. So that's being done. I know they're doing a study at Southwestern with that. But I think that's something we do too. You have to look at, if you get a scan and there's maybe one area of progression, everything else is stable and the treatment's well tolerated, maybe we can do radiation selectively in some of those cases to stay on the drug as long as possible.
Right behind you, Nicole.
Just is for myself. I'm considering before even a progression, I got few spots. I'm planning to go take a radiation.
Okay.
I know there is nothing out there that proves is going to change any outcome, but just testing the unknown.
I think some of these things are done on studies, so it'd be good if you might ask Dr. Gerber. Is he your doctor? Dr. Dow, his partner, or one of his partners. There is a trial looking at this, so maybe you'd be eligible for that. I think it's not unreasonable if you have only 3 spots and they've been stable, and there are situations where you might radiate them to maybe take you off treatment. Radiate them and continue treatment. Hard to know if you're responding is that the radiation is a treatment, but I think we'd have to take it individually and talk to him about it. I think it's not unreasonable.
My mother is the exact case that you guys are talking about right now. She is stage 4. She got on targeted therapy and reduced probably about 50% of it that we could see on scans, but there were a couple of spots that were growing. So Dr. Gerber got with the radiologist, and they decided that the best course of treatment was to try to hit those spots with radiation. We don't know how it's going to turn out because her first scans after the radiation will be next week. So we're hoping that it's positive and we can manage the rest of it, and hopefully those spots will be taken care of with the radiation. Now, since both of you guys are up there, this is for both of you. If that works, but maybe in the future those spots continue to grow again, or if perhaps the radiation just doesn't work for whatever reason, could you see, maybe not now, or either now or in the future, a place where everything else just seems to be so managed that you could even get to the point where even not radiation, but surgery at that point could be an option if it's so localized in one lobe?
Yeah, I mean, I think that we're starting to see more and more circumstances where that arises. Just starting to understand that. I think that it's sort of a case-by-case basis. It's not like, oh, there's an algorithm for that right now. Certainly I've operated on patients who've started out with very widespread disease, and then over the course of time and their treatment, it seems like everything's got away except that one spot, and then over time we sort of said, geez, it's just that one spot. And it doesn't seem, you always, as a surgeon, as a physician in general, but certainly as a surgeon, where what we do can cause significant discomfort and carry risk. Anytime we do an operation, there is always risk. So there's always weighing the risks and benefits for a patient. What is the risk of that particular operation? What are the potential benefits? And learning to understand that is important. But certainly there are patients that I've operated on who have disease that is over a more prolonged course has stayed under control with the exception of one spot, and then we've taken it out. So I see that, I'm a believer in surgery as a surgeon. Obviously, that's what I do and that's what I believe in. So I believe in surgery and I believe there's a role. And I see more circumstances for surgery arising in the future of lung cancer as opposed to less. I don't think that in our lifetime or my lifetime, or as long as it takes me to get my kids through college, that I'm going to be out of a job as a surgeon. And I think that there's always going to be a need for surgery in lung cancer, for the foreseeable future. I think that if you can remove it, that's your best chance. And I see more circumstances arising where cancer has spread, but it can potentially be removed at some point and add benefit.
I think lung cancer is evolving like some other, there are some cancers. In general, when you think about surgery in cancer, you're thinking about taking out the primary site before it has any time to spread anywhere. But there are some cancers that we do metastatectomy. In other words, you remove a metastatic focus, like kidney cancer, for instance, or melanoma, or colon cancer. We know that in colon cancer, you can sometimes have one metastasis to the liver, and if you take that metastasis out, the patient won't have recurrence. So we've learned how to do that in other cancers. I think we're learning how to do that in lung cancer. But there isn't an algorithm, you're right. I mean, it keeps saying this, it's individual, but it's true. There are some individual cases where you don't want to harm the patient. In other words, some patients just want surgery because I just want that thing out of me. But you have to make sure it's the right thing to do too. You don't want to just, as soon as a new spot develops, take it out, and then another spot, take it out. At some point, that's not healthy for the patient. So you just have to kind of find those isolated situations, or maybe there's an isolated spot that's growing. Everything else is stable. Radiation's one way to control it. Surgery might have a role. Just got to take it individually. So maybe it would be an option. I think we just keep that open.
Basis,
right.
And it just depends. Maybe in the future with more targeted
right.
therapies working, there are more cases where people regress and you have that spot left where it could be an option.
Yeah, this idea of one day treating like a chronic disease, we're going to use all our weapons in some fashion to try to have a long, healthy life living with the cancer, but make sure we're managing it and not harming anybody, but making sure that we can treat like a chronic disease is what we want to ultimately try to do.
Then the other one, I know Dr. Gerber touched on it, but he didn't really explain why. I think I was curious, and I think other people may be as well. He touched on why the genetic markers were not important versus they were, where there was that distinction between stage 4, they are important, and if it's not stage 4, then maybe not so much. Can you expand on why that is?
Just about what your treatment options are. So if it's stage 1, you take a cancer out, there's really no data right now that says if you give that patient chemotherapy or any kind of treatment after that, that you improve their survival. So the genetic markers, how the grade, that doesn't change. The size does, the lymph node status does, about maybe treatment after surgery. So immunotherapy doesn't have a role really in stage 1 or 2. Or targeted therapies have been explored, like you take out a cancer EGFR mutation, should you give that patient Tarceva for a certain amount of time so it doesn't come back? That's been done, that's been looked at. Some of these studies have been looked at, but at this point, standard of care, we don't use that data. I mean, it's nice to have it in case something happens and the patient develops disease down the road, but in the early stages, it doesn't affect our treatment decisions yet. I think that's what he meant.
We do have clinical trial where we're with a certain, I think, stage 3 cancers, we're testing through the clinical trial, and if somebody comes up with a mutation, then they can get randomized to targeted therapy. So.
And there's been this recurring theme and conversation at the tail end of this meeting, talking about, well, we don't know yet, right? And the data's not yet showing, which points back to the importance of patients participating in clinical trials, right? Less than 4% of oncology patients, adult oncology patients, actually participate in clinical trials. Therefore, a lot of things remain unknown, whether or not it's a drug that might have worked, for a patient, or a surgery that might be beneficial even in the latter stages. We don't know until we know. So just kind of wanted to point that out. Was there another question?
Yeah, my father is 84 years old, and right now he's using Tagrisso. It worked for him, and thanks Dr. Gerber for treatment. And I see a lot of development in this area, like the immunotherapies, vaccines. What do you see the latest development in this year, and what the future, what the trend for this area?
So you said he was on Tagrisso?
He's using Tagrisso.
Okay.
And I see this immunotherapy worked for him. I'm now thinking, what is the future? What is the latest development in this area?
What's the latest?
Well, it's funny because we have to figure out who is going to be the proper patient to get immunotherapy. Right now, when you look at patients with EGFR mutations, someone who might get a drug like Tagrisso, traditional immunotherapy, standard single-agent immunotherapy isn't working very well in that patient subset. So we need to figure out how do we treat a patient with EGFR mutation who progresses on the treatments that we have, how to give them immunotherapy. So that's being explored, maybe giving them an oral agent with immunotherapy. So what's being looked at now is how do you treat a patient after they progress on immunotherapy? How do you treat an EGFR mutation patient who's had Tagrisso or erlotinib, then Tagrisso, then what? And so that's being explored. There's lots of clinical trials going on right now looking at that subset of patients. So it's a combination. Immunotherapy trials, I think, are the future, trying to build upon that, maybe. But I mean, look, not all trials are positive either. I've certainly put patients on trials, and I've seen maybe they had more toxicity, and you have to realize that more drugs aren't always better too. So it's a path. It's a long path that we got to work through. And if you go on a trial and you don't get the drug, or maybe you got standard therapy versus standard therapy with the drug, it's sometimes that turns out that drug didn't add a benefit. So you just have to realize that these studies had to be done. We've got a lot of options right now. We're going to have a lot more options as these years go by. and it's exploding. There's going to be more and more trials, more and more drugs, and so hopefully these questions will be answered, and we're going to have more. I think just constantly looking for the next thing, and you're in a good spot. Your doctor has access to a lot of studies, and that's a good thing.
Yeah, we actually have a trial now for people who are progressing on Tagrisso, and we've added something trying to resensitize them. So that's kind of a new trial, but there's a lot of different things coming down the pipeline. So
I think this is another good segue into something I wanted Melissa to talk to you about, because I know it's an area you spend a lot of time in. I'm so sorry. Yes, go ahead.
I'm good. Thank you.
Oh. And it's side effect management, supportive care. Some of you may have heard it referred to as palliative care, which is, for most cancer patients that I talk to, a terrifying word, because most oncology patients are associating that with hospice care, which are completely different things.
Completely.
Can you talk a little bit about
Sure.
that?
So I am also certified as a hospice and palliative care nurse, and I've worked in both areas. And so, yeah, the word palliative care seems to scare everybody, and I try to explain that. You think of your oncologist as the expert at treating your cancer, but there are going to be symptoms associated with that, and this is the expert at treating those symptoms. They have access to social workers because, you know, once you get diagnosed with this, it's hard for your caregivers, yourself, and it's kind of an emotional roller coaster. And so they have social workers and psychologists to help with that, and pain management. They'll help you with, we've talked about goals of care. They're really good about taking time to sit down and really working with you on trying to figure out what's important. And I think, you know, just as a general person without cancer, I think we all need to sit down and do our goals of care and set up our medical power of attorney, because, you know, it's just something important to protect yourself and your family, and they can help with that. Hospice, on the other hand, is when you kind of exhausted treatment options, and you kind of not going to be on treatment. You can get care at home. A lot of our patients still come back and see us just in case something does come up and maybe they're feeling better, and so it's not like a permanent thing. So if you start feeling better, and you can always come off. It's not like once you sign up for hospice, we're completely out of the picture and that there's no turning back. So, but they provide, they have spiritual support, nursing support, aides, and you can have as little or as much contact with them as possible. It's very individualized as well. So, palliative care, usually the sooner you get that on board, the easier it is to cope with things and get through treatment and other things like that.
Yeah, this is an area where studies have actually been done to show that patients actually do better.
Prolonged, yeah.
Yeah, when supportive care is entered into the whole treatment plan at an early stage. And I know, again, in talking with patients over the years, sometimes patients are fearful of going back to their care team about what side effects they may be having for fear of being taken off treatment, right? And what they don't understand is that they're actually just making things worse, right? By not talking to their care team up front about that. Has anybody in here ever had used any sort of supportive or palliative care nurses or anything? No. Is it probably because as soon as somebody suggested it, you said no? We had a panel, we did a Presby, where Dr. Kirkpatrick works, is one of our community hospital centers of excellence, and we had a summit in Nashville back in December, and we had a patient panel, and everyone on the panel, when this question about palliative or supportive care came up, we said, were you offered? They said yes, and we were like, and your response was, and there was a lot of like bleeping that needed to be done, because there's such a misunderstanding about what it.
And we talked about like a multidisciplinary approach. And we talked about radiology, pathology, radiation oncology, surgery, but I think palliative care is another part of that multidisciplinary approach, because we all work together for the well-being of the patient. So,
I mean, I think palliative means to treat a symptom. I mean, so I always try to explain to patients that my goal is to, I'm going to treat your cancer, but I'm also going to treat your symptoms, and that's what it is. It's just a name and a label for treating symptoms. So I kind of take pride in doing both. I mean, I'm taking care of my patient. I'm going to look at the scan. I'm going to show them the scan. We'll look at their blood work. But I also, it's my job to take care of their pain, take care of nausea, take care of anxiety, and you know, it takes time, and you got to talk to your patients. But it's part of that's what I like about it. I think, you know, you're taking care of the whole patient, and that's what, you know, that's what we do.
Do you think that because I kind of associate even the clinical trial place, like a lot of patients I talk to, when I'm like, well, talk to your physician about clinical trials, they see it as sort of this last resort. What role can clinical trials play that aren't a last resort? Like when would you first maybe begin to talk about a clinical trial with the patient?
Well, I mean, I think you talked about clinical trial from the beginning. But, you know, there's also a fear of clinical trial, right? There's a fear of the idea of a placebo, or, you know, and then you have to explain all the different phases of clinical trials, because there are different phases. There's the early phase trials of drugs that really haven't really been given to humans much, and we're trying to figure out what's the dosing. And the people have to understand the goal of that treatment is what dose can we give and what are the side effects, and we hope for response, but they have to understand that. You know, phase 2 means you've done the work, you know the dose, and we're going to give it to everybody. There's no randomization. And then there's phase 3 when you're taking it and trying to compare it to the standard. So there's a lot of explaining to do, you know, because it's kind of it's a scary idea. A lot of people think, oh, I don't want to do an experimental treatment. So there's some fear. You have to sort of make sure that they understand it. But I think clinical trials should be something we're talking about from the get-go, because there are first-line studies, meaning if you've never had treatment before, that's a first-line trial. And then there's second line, there's third line. And so I always tell patients, before we start another line of treatment, let's make sure we've looked into trial options, because if I start another treatment, that might make you ineligible. So it's just, I think it's part of the discussion as you talk about your options, and it should be discussed at the very beginning.
yeah, I think it gives you kind of more tools in your toolbox. That's why I kind of like to think about it. So.
That's one of Bonnie's most favorite sayings, is talking
really?
about all the tools in her
Tools
toolbox.
in the toolbox.
Yeah.
My wife is looking at a clinical trial with Dr. Gerber right now, and as I'm reading through the information about it, I think one of the obstacles to it is, you know, we're going to the hospital once every 7 or 8 days right now. But with clinical trials, it's today, it's tomorrow, it's the next day, it's the next day, and there's a lot more, you know, it's like expected time at the clinic 3 hours, 4 hours, and when you're trying to balance work and life, the commitment with clinical trials seems to be a lot more than it is with the normal care.
Can be. Travel, you know, living in Dallas, and being in Dallas, we have MD Anderson in Houston, right? So I've got a lot of patients that go to MD Anderson, and back, and I co-manage them. So there's travel, you know, going to Houston, flying to Houston, driving to Houston, getting a hotel. Or if you're locally on a trial, some of them require blood tests that make you come in for hours before or hours after. So, you know, when you sign up or you look into a trial, you're getting this informed consent document. And they have to explain, here's what the commitment is. And a lot of times, patients will say, you know, that doesn't fit for me. You know, I just can't commit that much time, and I don't want to. So you're right. Some trials do require a lot of extra time. Some don't. Some it's an oral drug maybe you take and you check in once every 4 weeks. But if it's an infusional, maybe you got to go in every week, or maybe you got to go twice a week. So they're all different. Some are more labor intensive than others. But that's the whole point of that, informed consent, so you know what you're getting into and you decide this is not for me. And sometimes it's logistics that make people decide not to do it. But it is a lot of work, it's a lot of effort. And sometimes we don't think about that. I think when they design these trials, we want all this data, we want blood, we want samples, we want more biopsies, and the patient is, hey, I just don't want to do all that. And so it's part of how they design the trials. It's also part of, who can do what and how much time we have, what kind of support. We got our support system has to go to work. We need people to help you get back and forth. It's a big issue. So I think that is a barrier sometimes for studies. They can be too cumbersome and too time consuming.
I see a lot of it though. I think a lot of our trials at the very beginning, and there's a lot of testing and different, you have to see the ophthalmologist and do all this stuff at the beginning, and then as it goes, usually the visits kind of gets more spaced out from my experience for the most part. They're not all like that, but majority, I think it's get a little easier.
I think it's challenging for patients too, because the clinical trials and options out there for clinical trials are not easy for patients to navigate on their own, right? So that's
we
also
usually
a barrier.
get like a list, like Dr. Kirkpatrick has trials, Baylor. That's the thing is in oncology, like you were saying earlier, we don't really get offended if people go get second opinions. We want the best for you. And so if there's a trial that Dr. Kirkpatrick has, which we've had in the past, we will be happy to send you over that way because that's what's best for you. So that's the main thing.
That's one of my favorite things about Dallas and being able to share the community, being able to really focus on what's best for the patient first.
When you're talking about like second opinions and everything, like I believe my case.
I don't think you need a second opinion.
Oh, I thought you were going to say I don't think you need this microphone.
No, you need the microphone.
So with my situation, it was presented for a peer review. So doesn't the thoracic surgeon, the pulmonologist, and then the medical oncologist, is that considered as one opinion? I mean, to me, I would consider that as more than one opinion, because I'm sure y'all get in there and go, well, this, or whatever. Or is that one opinion?
No, that's a good question. So, but you would get that, theoretically, you get that same team approach if you went to MD Anderson, maybe you went to Southwestern, you went to Baylor. When you got an opinion, you would theoretically be getting a multidisciplinary opinion.
I would not go to another doctor.
Well, that's very sweet. But, no, but I think nowadays, when we, there's some situations where you don't need to get a surgeon involved, or you don't need to get a radiation oncologist involved. But if that's needed, you're going to get that typically wherever you go. So,
I wasn't sure if there's like a team review on all cases.
Not all places.
It's just a questionable, like.
Not all places, but
okay.
I think in general, from the beginning, if you had a disease that may require radiation, surgery, chemotherapy, and some combination, you would theoretically be getting a team approach at, say, MD Anderson or Baylor or Southwestern.
So if anybody has, I think we have time for one more question.
In the back here.
Perfect.
I just wanted to say, this is coming from an old research nurse, very old. I started in 1997. I've seen standard of care change because of clinical trials many times, and in the last 5 years, more than ever. And the clinical trial is set up for the patient's safety, so that's why it's cumbersome. There's so many tests, but it's set up for their safety. And then the outcome is really, you don't know for sure, but it's standard of care drug plus or minus a research drug. And so you're taking a chance, but it's something that I feel that the chance may be worth it. It's really, you just don't know for sure, but it's the outcome for clinical trials, at least the option for clinical trials should be available at your your practice, your physician's practice. And the more trials available, the better it is. So that's why I certainly support clinical trials, but it is cumbersome, there's no question about it, because there's more tests, but all the tests are based on making sure it's safe for the patient.
It's true.
That's a great point. Do you guys have any final thoughts before I close out? No? No? So I want to give a huge, huge, huge thank you to our panel for coming out and talking with me. This has been great. This is Dr. Mason's second year in a row coming out, and you actually moderated last year, right?
I did. You did a much better job
you're so sweet,
than I did. But one thing I wanted to say thank you for everyone coming. It was a much better turnout than last year, I have to say. And I think that seeing the faces of survivors and family members, it's so important. There's the run coming up pretty soon. When is that?
Yeah, that's in my housekeeping.
But it's so important. I think that the presence of survivors in lung cancer is not what it is in other cancers, particularly breast cancer. And I think we have the opportunity to do much more. And you guys are leading the way. And I'm really excited that you all are here today. It inspires us, and certainly I think will help many people who are following behind you who don't know what to expect or are afraid to ask questions.
Thanks. No, I agree. A huge thank you to all the patients in the room on the heels of what Dr. Mason just said. You, again, I'll repeat, are why we do this every day. So thank you for coming out and being a part of this and showing your faces in this community and to one another and sharing your stories. It means the world. Thank you to everybody signing in online. Thank you to the Cliff House. Isn't this place amazing? It's so pretty. Nice. So hopefully maybe next year we'll be able to come back to this very same venue. Thank you to the film crew who came out, and they got out here really early today and set up, like I said, a bunch of equipment you can't see in the back, but a huge thank you to them. To the caterers, Gill's Catering, and most importantly is to the patients. But one of the things, we could not do this without the support of our sponsors. Those folks who are out there ensuring that we can bring this to you not only on a monthly basis from back in California, but then bring it on the road to about between 4 and 6 different locations. And I have an amazing staff, colleagues in the room and those at home, like I said earlier, who I can't thank enough for helping to make all this happen as well. But our sponsors, I'm going to read these because I can't remember all of them. Bristol Myers Squibb, Lilly, Novartis, Genentech, Merck, Astellas, Celgene, Tesaro, Takeda, Medtronic, Boehringer Ingelheim, AstraZeneca, and AbbVie. A huge thank you to them for all of their support. I want to remind you guys, if you don't know, we've got a run. Both our docs up here on the panel brought it up earlier on April 13th at Continental Bridge, Trinity Grove out here in Dallas. It's an 8:30 shotgun start, which I hate. But I will be back. Bonnie will actually be here. So if you haven't met her and you would like to, come on out to the race that day and meet Bonnie. We'll also have a race on the very same day in Memphis, Tennessee. This is our second year in Memphis. And then our very next living room will be April 16th, broadcast back home from California, so be sure to tune in if you have the time. So thank you, everybody. There's coffee, there's dessert. Please feel free, help yourself and chat for a little bit amongst yourselves. Thanks, guys.
I'll see you.